Hello, good morning. I'm Joachim Deeg at the Fred Hutch Cancer Center in Seattle, and I want to welcome all of you to our meeting. It's the 8th meeting that we have organized on this topic of bone marrow failure. Unfortunately, we couldn't do it last year in person as it was planned, so this is a catch-up, so to speak. But lots of us and you have gotten used to this type of virtual interaction. So I hope we will still all derive the benefit from it, short of the personal interactions that we like to get from these meetings. You have seen the program. I think we have an excellent cast of faculty presenting state-of-the-art assessment of these bone marrow diseases ranging from aplastic anemia and failure states that may be genetically determined and inherited, even all the way to the transformation of these precursor diseases to leukemia. We have several of us who will be presenting live, as I am doing right now, and a number of contributors whose presentation has been recorded, either because of geographic distance, like Dr. Saucier in France, or people just having started their vacation. Nevertheless, we are planning to have a couple breaks and offer opportunity not only to ask, but also I hope to get answers to questions that you may have. And you know how to do that. You put your questions into the Q&A and we will address them at the appropriate time. As I'm speaking, you can see several slides projected here by our helpers from the Aplastic Anemia and MDS International Foundation, to whom I'm very grateful for the logistic support of this meeting. And of course, including the support by various commercial outfits that you can see here. So the way we will proceed is I will briefly introduce every speaker, very briefly. If you want more information, then let us know, and we can certainly provide that. With that having been said, let's start out. I think Herbert Louis Stevenson once said, "Old or young, we are all on our last cruise." Sort of sounds bad, but it's true. And what I'm trying to say is some of these diseases occur in very early childhood and others very late in age, but what we all want to get out of it, of course, is a beautiful cruise as long as possible. So Dr. Scott, whose presentation has been recorded, will give an overview of what is my diagnosis. And this is certainly an important question for patients. It's also a serious question for physicians seeing patients initially, because not all diseases are clearly put into boxes. There's a lot of overlap between them. So that's an important topic. Dr. Scott is a graduate of the University of Alabama and then did his training in medicine as a chief resident at Johns Hopkins before coming to Seattle, where he has been engaged over the last 20 years in research on myelodysplastic syndrome, myeloproliferative disorders, but as I said, a broad involvement. So without further ado, let's give Dr. Scott the word.
Hello, everyone. It's my pleasure to be with you today. I would prefer in person, of course, but we're all adapting to the way things are now. One of the benefits is that maybe more people are able to attend, and also it's a little bit more leisurely at home or your office, wherever you may be, rather than in a meeting room. So the topic of my talk today is, what is my diagnosis? And what I hope you come away with is an understanding of how all of your diseases are related to each other, and what we as experts look at to try to place you into different diagnostic categories. And also the fact that sometimes people can fit into multiple different diagnostic categories. So just some background information. We're dealing with blood and bone marrow failure disorders today. So I thought it might be worthwhile spending just a few minutes talking about what your blood is actually coming from. Inside the hard bones of your body is what we call the bone marrow. The outside of the body, outside of the bone is very dense and thick, but the inside of the bone is soft and whispery. It's got about 50% fat cells in there, and from the stem cells way of thinking, it's a great place to live because there's all these support structures that are built into the bone marrow to support your stem cells. And that's one of the important phenomenon that we see with these diseases, because the support structure cells may also have abnormalities as well as the stem cells. But the stem cells grow inside the bone marrow, and then over time they lead to basically 3 different major cell types. The erythrocytes, which are the red blood cells that give you energy, the myeloid cells, which help you to fight off infections, and then the platelets, which help you to prevent bleeding and bruising. And these diseases, the bone marrow failure disorders, can have low numbers of these cells or high numbers of these cells. And when you look at the different diagnostic categories, the major ones are myelodysplastic syndrome, myeloproliferative neoplasm, aplastic anemia, and PNH. Now, MDS stands for myelodysplastic syndrome. It can have some overlap with myeloproliferative neoplasms. The major issue with MDS in general is low blood counts with increased risk of infection and bleeding and a propensity to progress into acute myeloid leukemia, which is AML. Myeloproliferative neoplasms is a disorder where in general people make too much of something. It could be too many platelets, it could be too many red cells, or in some cases it could be too much scar tissue, which is what myelofibrosis is. Aplastic anemia is a problem not in making the cells, but really in the absence of stem cells. So patients with aplastic anemia have very low cellularity in their bone marrow, and their issue is not disordered production, but rather the absence of production. And then PNH is paroxysmal nocturnal hemoglobinuria. That's a complement-mediated disorder that has a lot of overlap with aplastic anemia and MDS, but essentially it's an autoimmune disorder where you attack your own red blood cells because of the absence of what we call complement blockers. Now, all of these diseases share some things in common. They're all rare diseases. They all have increased inflammation. They all have issues with what we call the bone marrow microenvironment, and that's the support structure that I mentioned that allows the stem cells to grow and mature in a proper fashion. And they all have a propensity to develop into acute myeloid leukemia. With MDS in particular, we are understanding more about the pathogenesis of why people develop MDS. We believe there's something that happens called the founder mutation, and this leads to clonal myelopoiesis, which is basically a collection of cells that are all derived from the same abnormal cell. They have all of these altered responses that you see here. It leads to low blood counts and increased cell death. That is what is manifested as MDS. And then they can develop additional mutations that leads to clonal evolution and leukemic transformation. So this is a pretty general slide. There's not a lot of specifics here, but our general understanding is that there's a founding clonal mutation that occurs in patients with MDS, and then over time there's clonal evolution that leads to acute leukemia. Now, not all patients with MDS actually progress to the second step to leukemia. Many patients stay in this area of ineffective hematopoiesis and increased apoptosis. In fact, most patients with MDS do not progress to leukemia. And most patients have what we call lower intermediate 1 risk disease with low blood counts as their principal issue. In regards to MDS, there's 9,700 new cases per year. It is actually more common than acute leukemia. The median survival is 2 to 3 years. We believe that the disease burden is likely underestimated. there is a strong age association that you'll see later in the talk. And so many patients are not appropriately worked up for their low blood counts. It's predominantly a disease of older age, a little bit higher incidence in men than women, about 1.2 times more common in men than women. And we do see that the incidence increases in age. This is just one scoring system that we use for patients with MDS, and you can see the survival with this scoring system, which is called the revised IPSS, ranges from 8.8 years to 0.8 years. Now moving on to aplastic anemia. So why do people develop aplastic anemia? There's two basic reasons. They can be born with it, that's congenital, with these congenital disorders that you see here. So this would be babies, very young children, or it can be acquired. So we know that certain infections can lead to aplastic anemia, pregnancy can, certain other autoimmune diseases, certain drugs, and certain exposures such as pesticides. The incidence of aplastic anemia is about 2 per million people in the West. It's 2 to 3 times higher incidence in Asia. We believe this is likely related to some type of exposure. There's a triphasic presentation. Very young people, we believe it's congenital, and then 20 to 25 likely acquired from some type of infectious etiology, and then over age 55, that's likely related to some type of environmental exposure. This is the actuarial survival of 292 patients with aplastic anemia. So you can see that it is not necessarily what we call a benign disorder. It's not considered to be a cancer, but it's certainly not what we would call benign, and many patients can die from their diagnosis of aplastic anemia. Now moving on to PNH. PNH is an acquired abnormality, so it's not something that you're born with, and it's an absence of what we call the PIG-A gene, or disorder of the PIG-A gene, that leads to no GP anchor protein. So here you see a normal cell. There's something called the GP anchor protein, which is represented by this squiggly line. It's a transmembrane protein on the surface of your cells, in particular the red blood cells. And this transmembrane protein binds CD55 and CD59 to the surface of the red blood cells. And it's basically a way of your cells to wave a flag that says that they're on the home team. So it helps your immune system to tell self from non-self. When your GP anchor protein is not being made correctly, and it's not located on the transmembrane protein, you cannot express CD55 and CD59 on the surface of your red blood cells. You're making CD55 and CD59, but you're just not able to raise the flag. So you could think of it as the flagpole missing, and therefore your immune system can't tell the difference between self and non-self. And the complement comes along and kills the red blood cells, which leads to hemolysis and the phenomenon of PNH. PNH is technically not a cancer. It can progress into a cancer, of course, but it also is not a benign disorder. And that's highlighted by this age and gender matched control comparison of survival. So here we have from a UK population, age and gender matched control. This is the anticipated survival of people over time. And then this is the actual survival of patients with PNH. I will say that this was in the era before the approval of several treatments for PNH, in particular eculizumab and ravulizumab, which are complement blockers. The estimated prevalence is 4,000 to 6,000. Historically, the 5-year mortality was 35%, but that's before the approval of complement blockers. Relatively young age, median age of 33, but you can see a range of 6 up to 82. It has a big impact on quality of life. There is a risk of progression to AML, and there's also a chance of spontaneous remission of about 15%. Now moving on to myeloproliferative neoplasms, and that's essentially where you make too many of something. This disease was described initially way back in 1951 by a physician who is famous to hematologists, known as Dr. Damashek. There's actually a prize every year named after him called the Damashek Prize, where you give a big lecture in our annual meeting. But this physician was very precognizant because he realized that all of these different types of myeloproliferative neoplasms had some common features. They were closely interrelated. They had variable manifestations of proliferative activity, And he theorized that there was some uncharacterized stimulus that would be driving this. Now, this is way back in 1951. Well, we now know that these stimulus are what we call JAK-STAT pathway activators. And there are a number of different mutations that have been identified. I'm talking about the three most common MPNs right now, PV, polycythemia vera, myelofibrosis, and essential thrombocytosis. There are other myeloproliferative neoplasms, in particular, a disease called chronic myeloid leukemia. That has a stimulator known as the BCR-ABL oncogene, and we're really not focusing on that disease today. But in regards to ET, MF, and PV, most patients have what we call a JAK2V617F mutation, and that is a known activator of this JAK-STAT pathway. Other mutations that have been identified are called calreticulin and MPL or MPL. TN stands for triple negative, and this is the various frequencies of these driver mutations in the different disorders. When you look at myelofibrosis, the incidence is about 0.3 to 1.46 per 100,000 people. The median age is 67. The prevalence is about 16 to 18,500 patients in the United States. This is a large retrospective assessment from the Swedish registry looking at survival over time of polycythemia vera, essential thrombocytosis in yellow, primary myelofibrosis in gray, and then what we call MPNU, which is a subset of myeloproliferative neoplasms unclassified, where we're not able to put patients into one of these distinct disorders. And what you see is that primary myelofibrosis has the worst survival, and ET and PV have the best. One of the other telling things about these population studies is that we have gotten better over time. So here in yellow is the survival of primary myelofibrosis between 1980 and 1995, and in blue, the survival between 1996 and 2007. And you can see that we've been able to improve survival of primary myelofibrosis over time. And this is looking at survival of myelofibrosis by age group and over time. And regardless of which age group you fit into, over time, survival has improved, in particular for those older age patients. So we have made improvements in the treatment of these diseases. Just one other thing to point out here, if you look at what we call the 20-year relative standardized ratio, that's comparing basically survival to a standardized population. So it's a way of us saying, what would the survival expected to be of patients if they did not have polycythemia vera or essential thrombocytosis? And you can see that for myelofibrosis, the survival at 20 years at 0.06 is a much lower number than what you would expect for ET or for polycythemia vera. So just reiterating that primary myelofibrosis has the worst survival. And this is really a disease where we would consider intervention with allogeneic transplant, whereas with polycythemia vera or essential thrombocytosis, we would not really consider that intervention because they typically have a better survival. Age. There is an important relationship between age and bone marrow failure. PNH tends to be younger. MDS and myeloproliferative neoplasms tends to be older. Aplastic anemia has what we call a triphasic presentation, young, in the 20s, and then older age. And it does vary in different regional areas. So if you look at Israel and Europe, when you see aplastic anemia, you're more likely to see it at an older age, whereas in Asian countries, you're more likely to see aplastic anemia at a younger age. So there are geographical differences in the incidence in regards to age for aplastic anemia. There are a lot of studies to try to determine why that may be the case, but it could be due to different types of toxic exposures or different type of infections that may be present in these populations. All right, so moving away from the epidemiology of disorders and talking about classification and prognosis, I think it's important that you have some general understanding of what we call cancer genomics. So this is a patient-friendly explanation of cancer genomics, but it is an important concept, I think, for patients to understand because it's increasingly important in how we diagnose these disorders and how we risk stratify these disorders and how we choose treatment for these disorders. So when you have a tumor cell, a cancer cell, it has inside of them genes. these genes are tightly bound into chromosomes when the cancer cells are dividing. We call that metaphase. When we do something called a chromosome test or a karyotype, we're looking at whole chromosomes that are tightly bound and wrapped into these figures that look like X's. The short arms are called P's, the long arms are called Q's, and where they come together is called the centromere. So when we do what we call a karyotype analysis, we're able to see are patients missing large portions of their chromosomes. So one MDS disorder is called deletion 5q. What that means is that on one of the long arms of chromosome 5, a portion of it is just missing. So this long arm here is gone. So that would be what we call del 5q MDS. Another type of phenomenon that you can see is in MDS is called the SF3B1 mutation, and that's increasingly important from treatment decision. But the SF3B1 mutation is actually a point mutation that occurs in the small level. So you're not going to be able to see an SF3B1 mutation through a karyotype test. You have to do something called a myeloid gene panel or a gene mutation test. I will say that as physicians, we don't do a great job with this because we call things multiple different names. So it can be confusing from a patient's perspective. But it is increasingly considered standard of care that patients have what we call a myeloid gene panel or a gene mutational panel to look at their particular type of cancer. So we look at this information and it helps us to diagnose patients, risk stratify patients, and also to choose treatments. So with MDS, that would be reviewed. Your bone marrow would need to be done, and we would see what we call dysplasia or an increased blast count or karyotypic cytogenetic abnormalities. So obviously I'm not going to go through this in detail, but these are different types of karyotype whole chromosome changes that if we see them, we say, okay, that's enough evidence to make a presumptive diagnosis of MDS. If you don't have these karyotype abnormalities, then you need dysplasia, or you need bone marrow blast count increased, or peripheral blast count increased, or what we call IRODs, and then at least one cytopenia present. And then you need to rule out secondary causes of dysplasia. So a thyroid test, a B12 level, a copper level, and then alcohol use, because that can also be confused with MDS. So when we do the bone marrow, these are the types of things that we would look at to make the diagnosis of MDS. The dysplasia can be subjective and can be difficult to quantify, which is why I think it's important that you have your bone marrow slides reviewed by an expert pathologist. This is the current classification system. One thing I do want to point out is this idea of ringed sideroblast. Patients who have an SF3B1 mutation, so you see the little cross here, don't necessarily have to have a very high ring sideroblast count to make that diagnosis. Without the SF3B1 mutation, you'd have to have 15% ring sideroblast or greater. The reason why this is more important is because there's a new drug that's FDA approved specifically for patients with ring sideroblast called luspatercept or Reblozyl, which will be a topic of Dr. Kamraji's talk. When we look at the cytogenetics, it's very important in regards to prognosis, and we can put patients into different groups based on the types of karyotypic abnormalities that patients have. There are two that are considered to be pretty bad, and that's called a monosomy 7 or loss of chromosome 7, and then abnormalities involving the long arm of chromosome 3. We look at your cytogenetics, your bone marrow blast count, your platelet count, your hemoglobin, your neutrophil count, and we're able to develop this prognostic model called the IPSSR and place you into one of these different prognostic groups, which helps us to choose different types of treatment interventions. So in general, we would reserve transplant for patients who have more high-risk disease, and for patients with lower risk disease, we would choose different types of treatment options that don't necessarily involve stem cell transplant. Mutations, as I mentioned, these are the point mutations where you go through and you do these myeloid mutation panels, have been shown to be relevant from a prognostic perspective. It is anticipated that the next prognostic model will include mutational abnormalities. And there are mutations that are listed here in red that have been shown to have a poor prognosis. And then there are mutations that are listed here in green that have been shown to have a good prognosis. This is specifically for MDS. There's other types of mutations that are important in MPNs, aplastic anemia, and even MPNH. But we would look at these different types of mutations, and it helps us to further clarify your prognosis. So moving away from the diagnosis and classification of MDS to aplastic anemia, for aplastic anemia, we look at the cellularity in the marrow, and we look at the severity of the low blood counts, and we place patients into these different classifications. And it is predictive of survival, and patients with very severe or severe aplastic anemia have a worse survival. So for patients who have a matched sibling donor who are less than age 40 with severe or very severe aplastic anemia, our current standard of care is to offer them allogeneic transplantation up front. Centers on the East Coast may prefer to give these patients immunosuppressive therapy, but our preference is to offer them allogeneic transplant. Now, if they're over age 40, or if they don't have a matched donor, or if they have moderate AA, then the upline approach would be what we call immunosuppressive therapy. And Dr. Kill will be speaking more about this later today. With PNH, we think of it as 3 different types of diseases. There's classical PNH, which is what everyone kind of has heard about. And with that, you have really classical hemolysis. So it's a Coombs negative hemolysis. Sometimes you can see both classical PNH with a bone marrow disorder, aplastic anemia, MDS, or myelofibrosis. And then there's another phenomenon called subclinical PNH. In general, these are patients with aplastic anemia or MDS who have a very low level of what we call PNH. So we're able to measure the level of PNH in a patient by doing flow cytometry on their blood. And at least in this older series of patients, that was predictive of survival. I will say that the survival was worse for classical PNH, but this has likely changed now that we have complement blockers available like ravulizumab and eculizumab. All right, myeloproliferative neoplasms. So you can see the category of myeloproliferative neoplasms is fairly complex. And one of the first tests you would do in a patient with myeloproliferative neoplasms is what we call a Philadelphia test. And if they're positive, they have CML. If they're negative, then we look at what we call the driver mutation. And patients with JAK2V 617F generally fall into primary myelofibrosis, polycythemia vera, or essential thrombocytosis. As I mentioned, they could also have calreticulin or MPL, or in fact be triple negative. And the JAK2 mutations leads to overactive signaling of what we call the JAK-STAT pathway. And the activation of the JAK-STAT pathway basically leads to increased division of the stem cells and increased growth of either platelets, red blood cells, or fibroblasts, which leads to either polycythemia vera, essential thrombocytosis, or myelofibrosis. But we have a greater understanding of the molecular pathogenesis of MPN currently than we have in the past. When you look at the diagnosis, you do want to do molecular testing for the JAK2V 617F because it's part of the diagnostic criteria for PV and for ET. And then for both ET and PV, it is recommended that patients have a bone marrow performed. For PV, it's not required if you have sustained absolute erythrocytosis. But if you do see fibrosis, that can offer some prognostic information. So we do recommend that patients with ET and PV have a bone marrow performed. For myelofibrosis, it is required that you do a bone marrow to show megakaryocytic proliferation and atypia. It is difficult, I will say, to distinguish between the disorders of MPN, more so probably than any of these other diseases. And I do really think that it's important to involve someone who has expertise in these arenas to confirm the diagnosis of PV, ET, and MF. Our current prognostic models look at whether patients are older and whether they have a history of thrombosis, and if they do, they're considered to be higher risk for both ET and PV, and this has been shown to predict survival. This is a recent study. I'm trying to give you some updates here from our recent meeting of ASH. But one of the interesting things about this study is that in PV, they found that blood clots, thrombotic complications, was the leading cause of death in patients with PV. So our treatments should be really aimed at trying to prevent death from polycythemia vera. The 4-year mortality was greater than 10%, and a third was due to thrombotic complications. This is an IPSAT predictive model, but this is a different type of model that we would use to predict survival in patients with ET and also the risk of thrombosis. So we also look at these factors in addition to age and history of thrombosis. And one of them is a high white count. So if you have a high white count with ET and likely with PV as well, that does increase your risk of thrombotic complications. Our current model for prognosis in myelofibrosis is called the MIP 70+. At least this is what I use. It looks at these varieties of factors that are listed here. I will point out that HMR stands for high molecular risk. So we are incorporating mutational abnormalities into our prognostic algorithms for myelofibrosis. And you can see that it's very predictive of survival. So if we have a young patient who's otherwise low risk but has an ASXL1 mutation, for instance, we might consider earlier intervention with allogeneic transplant in that patient. In regards to presentation, patients could have no symptoms. They could have symptoms related to low blood counts, or they could have symptoms related to high blood counts. Patients with PV or ET, for instance, can have problems with itching, burning pain, and skin redness. There are higher rates of gout in patients with myeloproliferative neoplasms. Hemoglobinuria occurs in about 26% of patients with PNH, and by far the most common complaint that patients with PNH have is fatigue. In my opinion, the fatigue is very severe, and it's out of proportion to their degree of anemia. When we see a patient with these disorders, we want to do some blood tests, looking at a variety of different things. I already mentioned B12, copper, and TSH levels. Serum erythropoietin levels are also useful at baseline for patients with MDS. Of course, to make the diagnosis for sure, we would need to do a bone marrow. Myeloid mutational panels are really standard of care for us at our center for patients with these disorders now. And I think it's going to be increasingly used in all of these disorders. And as I mentioned, for patients who have ring sideroblast, it is an important part of the diagnostic algorithm with SF3B1. The diagnostic test for PNH is called flow cytometry, and it should be done on the peripheral blood. And we look for absence of these GP anchor proteins, CD55 and CD59. This is an example of flow cytometry on a patient with PNH. Here, they have an absence of CD59 on their red blood cells, which are shown in these two peaks. So that helps us to determine how many of the red blood cells are missing the GP anchor protein. I'm not going to go through this in detail, but we basically look at different bone marrow findings in the patients to help distinguish between these disorders. And in general, patients with aplastic have a low cellularity, whereas patients with myeloproliferative neoplasms have a high cellularity. So the conclusions are that bone marrow failure syndromes are difficult to diagnose, so it is important that you involve an expert center. The clinical and diagnostic studies, honestly, are imprecise. We are trying to improve that, but even among experts, there can sometimes be disagreements about which categories patients may fit into. This is further complicated by the fact that many of these entities overlap. And in fact, sometimes patients may initially be diagnosed with ET or PV, and then later on cross over into PV or ET. And then these patients can also develop myelofibrosis at a later time point. And then there's a disease entity called MDS MPN, where patients have both problems with MDS and with MPN. So from all those reasons, I do think it's important to involve a center with expertise when the initial diagnosis is made. Cytogenetic testing is considered standard of care, and molecular testing is increasingly important. And with that, I would like to thank you for your attention, and there will be a question and answer session that will be held later in the day. Thank you very much.